Buenos días a todos. Es una lástima. It is a pity that I cannot be with you in person today, as I would like to be. También lo siento, I am very sorry that I cannot speak in Spanish, but this may be an advantage for you because you may understand my English better than you would understand my very poor Spanish. The topic today is the importance of primary care. We always knew, at least since Alma Ata, that primary care is very important. But until recently, we did not really know what primary care is. Now we do know exactly what primary care is, and more importantly, we now know how to measure it and to evaluate it. We know how to do that, which we did not know when Alma Ata was proposed. This presentation summarizes what we know about the very important benefits of health systems that are oriented to primary health care and to primary care. The first slide shows the density of health professionals, and that's total health professionals, not just physicians. The density of health professionals plotted against infant mortality, that is, infant and early childhood mortality to 5 years of age. And you can see from this diagram that there is a general relationship such that the higher the density of health workers, the lower the child mortality. And this is a relationship that will not be surprising to you, as it is well known. But what is much more important is the fact that there is a lot of variability across countries in how many health workers they have and how high their early childhood mortality is. So this means that it is not just the number of health professionals that make a difference to this very important aspect of health, but rather it is what these professionals do that makes the difference to early childhood mortality and, in fact, to other aspects of health. There is great variability, and that variability gives us a lot of clues as to what we should look for, including primary care. Now, let us make a distinction between primary health care and primary care. First, Alma Ata talked about primary health care, so we can define primary health care now as primary care applied to the whole population, to a defined population. It is a strategy directed at the population, and it requires the commitment of the government to develop, in conjunction with other services that are oriented to populations in the context of other levels and types of development. That is, it is system characteristic. Primary health care is the characteristics of a health system that support the development of primary care at the clinical level. Now, primary care at the clinical level, Atención Primaria, is primary care offered as the first point of contact, oriented to the person and not to the disease, that satisfies the needs, the health-related needs of each person. It refers to specialists only those patients with problems too rare or uncommon to maintain competence in primary care. And primary care coordinates care when people do have to receive care at other levels of health services. So primary care is the reflection of the system characteristics on the clinical characteristics, which include four things: first contact care, person-focused care over time, comprehensiveness of care, that is taking care of all the problems that can be dealt with in primary care and referring only those that are uncommon, and coordinating care when people have to receive care elsewhere. Now, why is this important to the health of people and populations? It's important because primary care health system gives better results in health at lower costs and with better equity in health, that is, better distributions of health across different population groups within the population. So first we will talk about evidence of the benefits of a health system oriented to la atención primaria. These are the results of a study that was done in two different periods, once in the 1980s and once in the 1990s, in many different countries, divided into three groups. In this slide, I have divided the countries into three groups. The top group are countries with low scores to primary care. The middle group are the countries with intermediate scores, and the bottom group of countries are the countries with good primary care. So in the first group are Belgium, France, Germany, and the United States. In the second group are Australia, Canada, Japan, and Sweden. And in the third group, the group with the highest scores on primary care, are Denmark, Finland, Holland, Spain, and the United Kingdom. Now, the scores are derived from a combination of different measures of Atención Primaria de Salud, primary health care, and scores for the clinical aspects of primary care. By the way we scored these characteristics, the minimum score was 0 and the maximum score was 2. And you can see very clearly that at two different points in time, in the 1980s and in the 1990s, there were large differences in the scores for primary care, the combination of the system characteristics and the clinical characteristics in the three groups of countries, and that the scores did not change very much between the 1980s and the 1990s. This is a graph that shows the scores for primary care plotted against the total costs of health care in 1997 in these same countries. And what you will see here is that the higher the score for primary care, with the United Kingdom at the very top, the top score for primary care, the higher the score for primary care, the lower the total costs of the health system per capita. And if you do statistics on these plotted figures, you can see that the score is directly related to the cost. There is a statistically significant relationship such that the better the primary care, the lower the total costs of health systems. And this is true even if the United States, with its very high costs, is removed from the statistical analysis. This is another graph that plots the ranks of the different countries on primary care against their ranks for health outcomes. We used 16 common health outcomes, including life expectancy, death rates at different ages, low birth weight, infant mortality, and things such as this, very common indicators. And we ranked each country according to how well they did on the results against their rank for primary care. And the number one rank you see at the bottom is the United Kingdom. It had the highest rank, that is the number closest to 1, whereas the United States had the worst rank for primary care. The United States also had the worst rank for health outcomes, and the graph shows you very clearly that there is a general relationship such that countries that are better oriented towards primary care, and that includes the system characteristics as well as the clinical characteristics. There is a relationship between the rank on those characteristics, the total score, and health outcomes overall. Now, we have found that countries oriented toward primary care have fewer children born at low birth weight, have lower infant mortality, especially post-neonatal mortality, have fewer years of life lost from suicides, have fewer years of life lost for total mortality, except for external causes which would not be expected to be responsive to primary care or to medical care in general. And they have a higher life expectancy at all ages except at 80 years of age. And even at 80 years of age, the countries that have high primary care scores are beginning to be better than the low primary care countries, even at these high ages. This is from a very sophisticated study that controlled for other things in looking at the relationship between the primary care score and premature mortality in 18 OECD countries. These analyses were controlled for other influences on health, including the percentage of elderly people, the gross domestic product in purchasing power parities, the total doctors per capita, and the percent of the population that smokes or that drinks at a high level. And we have plotted the score for primary care in these 18 countries against premature mortality over a 30-year period from 1970 to the year 2000. The red line, that is the line at the top, are the countries with poor primary care scores. And the blue line, a line at the bottom, are the countries with better primary care scores. And for the last 30 years, it has always been the case that countries with high primary care scores have lower premature mortality than the countries with poor primary care. But more importantly, for our interest in developing primary care in the Americas and elsewhere in the world, is that this difference is increasing over time. That is, the advantage of primary care is getting greater over time by this measure of health, and it is also the case for other common measures of health. These are the average ranks of scores using the measures that the World Health Organization used in the year 2000 report on health in the different countries. And these are total ranks for average years of life without disability, equity in survival of infants, and general health. And I have given you two groups of ranks. First, the ranks for the poor primary care countries, and second, the ranks for the countries that are better oriented toward primary care. And the lower numbers mean higher ranks, better ranks. And you can see very clearly that for these measures of health that were used by the World Health Organization, the better primary care countries have much better ranks for these three measures of health than the countries that are poorly oriented towards primary care. Now, we have shown that primary care is very important in international comparisons of countries. Is it equally important within countries, within different countries? Now, this is a graph with data from the United States, which plots the number of primary care physicians per population against expectancy of life. And we have plotted the regression line to show you that the higher the number of primary care physicians in the 50 states in the United States, the higher the expectancy of life. There are some very marked deviations from this line. The state on the bottom right of the slide is Maryland. It has a lot of primary care physicians, and it has a low expectancy of life. And that is, we think, due to the fact that in addition to a very high number of primary care physicians, it also has a very, very high number of specialists. And we shall see in a few slides that not only is a high primary care physician ratio important, but so is the specialist ratio, because we have found that where specialist ratios are very high, generally health is poorer. This slide shows data from Indonesia from 1996 to 2000. Now, during this period of 1996 to 2000, the attention that was devoted by the healthcare system to primary care decreased from what it had been in the early 1990s. And you can see on the top row that the costs of the expenditures for primary care per capita decreased over the period 1996 to 1999 and 2000, at the same time, on the second line, as the expenditures on hospital care per capita were increasing. So during this period, when expenditures for primary care were decreasing and expenditures on hospitals were increasing, there was a worsening of infant mortality, a 14% worsening of infant mortality in 22 of the 26 provinces, whereas before this change in the healthcare system in the early 1990s, there had been a 20% improvement in infant mortality in all of the provinces in the country. This is a slide showing the findings of a study in Petrpolis, Brazil, in the year 2004. And what the investigators did was interview people that were coming to primary care clinics in this large city in Brazil. And they found out by interviewing the people, they found out how they rated their primary care according to the characteristics that we talked about previously, that is, first contact care, person-focused care over time, the range of services provided, and the coordination of care. And they asked people about their experiences with these characteristics. They also knew the age of the people. They also knew whether they had a chronic illness, whether they had a recent acute illness. They also knew the family income, and they knew the education level of the individual who was interviewed, as well as the type of clinic that people were going to. Of all of these characteristics, the most important one in influencing self-perception of health as good or excellence was, in fact, how they rated their primary care experiences. It was even more important than family income, and more important than their age, and more important than their prior experiences with illness. That is, the better they rated their experiences with primary care, the better they rated their health. Many other studies done within countries demonstrate that regions with better primary care have better health results, better outcomes of health in terms of total mortality, cardiac mortality, rates of infant mortality, early detection of different forms of cancer, such as colorectal cancer, breast cancer, uterine and cervical cancer, as well as melanoma. That is, the better the primary care supply, the better people's experiences with primary care, the better these health outcomes. Now, the case is exactly the opposite with regard to the number of specialists per population, in which case all of these results are worse. That is, the higher the number of specialists, the worse these outcomes. So what we know is that a system oriented toward primary care is important for improving effectiveness of health and for maintaining low costs, that is, costs at a level that can be supported by the health system. So now we ask the third question. We ask, is primary care related to reductions in inequities in health? So first, let us define what we mean by inequity in health. Equity in health is the absence of systematic inequalities in health that are potentially remediable in one or more aspects of health among groups in the population defined in terms of geography, demography, or social characteristics. And inequality is the presence of systematic and potentially remediable differences in one or more aspects of health in different groups of the population. Now, this definition, just like our definition of primary care, is measurable. We know exactly how to measure inequalities that are systematic and potentially remediable in different groups of the population. Now, some studies have looked at the impact of primary care on inequity in health, and this is one of them. In the United States, one additional primary care physician at the state or local level is associated with a reduction of 1.44 deaths per 10,000 inhabitants. That is, as we said before, the higher the number of primary care physicians, the lower the mortality. From the point of view of equity, the relationship between the number of primary care physicians and lower mortality is much stronger in the most deprived subgroup of the population, the African American population, and populations of low income in the white population. That is, although primary care is very important for better health in the total population, it is even more important for deprived populations, whether measured racially or socioeconomically. Other studies have shown that in 7 African countries, the 20% of the population that is most wealthy receives more than double the financial benefits of government budgets than the other groups in the population. That is, the richest 20% get 30% of government expenditures, whereas the poorest 20% of the population get only 12% of the government expenditures. But for expenditures on primary care, the poor-rich ratio is much different. That is, for primary care expenditures, the richest 20% get 23% of the expenditures, and the poorest get 15% of the expenditures. There is still inequality, but it is much less of inequality than is the case with total healthcare expenditures. And that led Dr. Watkin, who is a student of primary care in various countries, to say that from the perspective of equity, primary care clearly represents a step in the right direction. Many studies also demonstrate the benefit of reforms oriented toward primary care. Studies in Bolivia, primary care reform in deprived areas diminished infant mortality, or mortality under 5 years of age, whereas it did not do that in areas that did not undergo primary care reform. In Costa Rica, primary care reforms over the past several decades have decreased infant mortality and increased expectancy of life as compared with the other underdeveloped countries. In Mexico, greater attention towards primary care reduced infant mortality in marginal areas, in deprived areas where primary care reform occurred. This slide plots the gross domestic product per capita in purchasing power parities against life expectancy in many different countries of the world, both developing countries as well as industrialized countries. And it shows that at low gross domestic product per capita, the higher the GDP per capita, the better the life expectancy. And this is something that has been known for a long time. But what has not been known for a long time, and is very significant, that above a certain level of wealth of the country, life expectancy is decreasing. And that's the case for the United States, way on the right. It's the case for Switzerland, another wealthy country. And it is also the case that life expectancy is lower than expected for wealth in countries such as Singapore, Germany, and Taiwan. Now, it is not really clear exactly why this is the case, but we believe that it is almost certainly at least partly related to the fact that in very wealthy countries, a lot of money is being spent on specialty care, which is not effective in improving the health of countries overall. This is a slide that was developed by the Karolinska Institute, and it uses data from the mid-1990s, so it may be a bit out of date in terms of countries that are undergoing primary care reform. It plots the gross national product in purchasing power parities against child survival to age 5 in 177 countries of the world with more than 100,000 inhabitants. The colors refer to the continent. So the large circles there are China and India, the large red circles. The size of the circle is the population of the country. And this graph shows that there is a general relationship between wealth of the country and child survival to age 5. But like the previous slide that I show you, this appears to be mostly the case in countries which are not very wealthy, because once you get to countries that are very wealthy, there is a definite plateau. The other thing that is very interesting in this slide is, as I showed you in the slide about the health professionals and child mortality, there is tremendous variability across the country. In the middle of the graph, you have Cuba, which has a level of child survival exactly equivalent to the United States. And although it has the same wealth, gross domestic product, as all of the countries that lie below it, it has much better child survival, undoubtedly due to its social characteristics, but also, very importantly, its high focus on a primary care orientation of its health system. These data come from this previous slide, and what I did was I plotted countries that had similar gross domestic product, but very different percentages of government expenditures that are directed at the poorest 20% of the population, as compared with the most wealthy 20% of the population. So on the left-hand slide, on the left-hand side of the slide, you have Sri Lanka, Malaysia, Costa Rica, Jamaica, Nicaragua, and Egypt, which have high infant survival. And they are matched with countries on the right, which have the same approximate wealth, but with low infant mortality. Ivory Coast, Brazil, South Africa, Ecuador, India, and Ivory Coast. And the ratios that I give there are the ratio of expenditures to the poorest percent of the population compared with the richest population. So you can see that the countries on the right, except for Egypt, actually spend more on the poor than they do on the rich in terms of government expenditures, whereas the countries on the right spend much more on the rich than they do on the poor in terms of government expenditures. And the last column on the right shows that the number of children who are lost per 1,000 born is quite large. 150 more children survive in Sri Lanka than in Ivory Coast of 1,000 children born. And in every one of these cases, the countries where government expenditures on primary care for the poor are greater than they are for the rich have many fewer children lost in the first 5 years of life. Now, what are the characteristics, the specific characteristics of primary care, which are evidence-based? We know very well and with very robust statistics that countries with strong primary care have overall costs of health care much lower and populations that are much more healthy. And we know that within countries, areas with greater availability of primary care, but not availability of specialty care, have populations that are healthier, and that the greater availability of primary care resources reduces the adverse effects of social inequalities. So our conclusion is as follows, that the eminent great pathologist Virchow said that medicine is a social science and that politics is medicine on a grand scale. And now we know, more than 1 century later, that better health and better distribution of health are thanks to primary care, together with improved social conditions and improved environmental conditions as a result of public health policies and social policies. Primary care is a very important aspect of politics in countries to improve efficiency, effectiveness, and equity in health and health services. There is no doubt that socioeconomic factors influence health, but there is also no longer any doubt that primary care services within the health sector constitute a very important influence in improving health, and in doing so rather rapidly and very clearly in preventing advance in illness and avoiding the dangers, the adverse effects of health care, especially so at younger ages, but also at other ages. So I would encourage you, in whatever country you are, to pay attention to developing health policies at the governmental levels that facilitate the achievement of good primary care at the clinical level. I thank you very much for inviting me to give this talk, and I wish you good luck in the development of your primary health care systems.